Hi everyone, good afternoon guys, and welcome back to the second day of pathology questions, where we are going to discuss questions which are first and foremost applicable to all set of students. So before this confusion arises, it is important for NEET, NExT, FMG and INI-CET, because I believe that clinical questions are just not limited to any one exam pattern. Clinical or integration will be a part of every exam pattern, be it of the past or of the future. So when you enter these sessions, I always believe and I always tell you that whenever you sit down for an online class or any other class, just try to detach from all the news and rumors and exam notifications that you have been dealing with, and try to give in your 200% into focusing only on what is being taught, because that ways you will be able to detach and you will be able to concentrate more, and that is what is needed, especially the students who have an exam in July, that is FMG, or the students who are targeting NEET 24 or INI November. For you guys at this point of time, focusing is the most important so that you don't waste any time, which of course you have wasted in the past 1 week, by listening to so many of these notifications. So I guess we are good to go, and I believe everyone's joining in. So let us get going. What's the plan? We have a few questions. Integrated questions means renal path comes to your mind. Let's practice one or two questions of CNS pathology, one or two questions of hemat. So I'm trying to touch upon every topic, or trying to touch upon every subtopic and chapter in a manner so that you get an orientation that, okay, these are the kind of questions, and pretty much nothing is going to change except for the length of the question and the approach to the question. So I'm again and again saying it's about training the brain. So train the brain series is what is there, and many of you had requested that we should have a similar session for micro also. So here it is. The next session will be on July 17th, again at 12 o'clock, where we are going to discuss similar questions for microbiology. That's also going to be a YouTube class. Okay, chalo, all orientation part is done. Let us get going with the questions. Here you go. Question number 1 in front of all of you guys. Let's start with this. Okay, so here you have a 60-year-old female who's come for a routine medical, come with a medical history of long-standing type 2 diabetes. A big hint that is given out there. Has come for her follow-up assessment. She reports typical diabetes features: increased thirst, there's polyuria, there is unexplained weight loss present. Physical examination also shows hypertension and peripheral neuropathy, which are basically going into features of diabetic neuropathy. Are the kidneys being affected? Yes, diabetic nephropathy is also there. Of course, that is a situation, and they've given you a histopath. So now when I come to a case of diabetes mellitus, I am expecting neuropathy, I am expecting nephropathy, but the histopath given over here is of a nephro lesion, is of a kidney lesion, and very well everyone has marked it over here as nodular glomerulosclerosis. Some of you, I know, as soon as you read diabetes and kidney, you were searching for what? You were searching for Kimelstein-Wilson lesion. You were searching for that term. Now that is not written. The other name for KW lesion is written, and that is nodular glomerulosclerosis. I'll explain this picture to you. Pehle look at the other options. Why are they not other cases? Because classical diabetes ka history tha, I had to pick up this. But otherwise, if it would have been a case of acute tubular necrosis, one cast would have been written: necrosis, kidney is dying, the tubules are dying. कोई poisoning होगा, mercury poisoning, some chemical, toxin, kidney is dying. So I would have found a cast written in the question, and that was the muddy brown cast. Ma'am, some dirty cast would have been found in the urine. Exactly, death होगा, so some dirty brown material will come in the urine, which was not there over here. So ATN, and there is no history of any poisoning also. Na kuch hota, mercury poisoning, ethylene glycol poisoning, nothing is written. Okay, coming to the next, membranous nephropathy. I think by now everyone knows a very famous pattern. This ECG kind of looking pattern, what have I made for membranous nephropathy? It shows you the spike and dome pattern, which was again not mentioned over here. Coming to the next, segmental glomerulosclerosis. Segment, guys, look at the word segment of glomerulus. Entire, pura, full glomerulus is not going to be affected. Segment of the glomerulus will be affected. Matlab, one half of it would have been affected. There is nothing like that. Over here, the entire glomerulus is affected. And what is it? Now let me show you the picture. Look at this, guys. This is nodular glomerulosclerosis or Kimelstein-Wilson lesion. Try to break the word. Sclerosis, matlab, ma'am, as always, pathology has something pink material will be seen. Where will it be seen? It will be seen in the glomerulus. glomerulus, kaisa arrangement hoga, what is the arrangement? It is going to be nodules. So now let me look at the picture. Nodules, glomerulus, sclerosis. Let's zoom into the picture. I can see a big glomerulus over here. Yes, this is a huge glomerulus, and inside this glomerulus I can see the presence of, ye dekho, pink color ka nodule, pink nodule, one nodule. So many nodules are there. So that is why I am calling it nodular glomerulosclerosis, and that is the other name for KW lesion. This is simple. Ye bahut easy question tha. Let's add a little bit of spice into this question. If they would have asked you, tell me a special stain for Kiemelstein-Wilson lesion or KW lesion. So all these nodules that are shown over here, they are pass positive. That's adding a little bit of, extra element to this question. Now let me actually correlate this with how I would expect a question to come. So for example, the same question is given and the answer is also given. This was also given that the picture is showing you KW lesion. Now they ask you, you want to do a testing of type 2 diabetes mellitus. What are the tests that you're going to do? This person is a known case. She has type 2 diabetes long standing since many years. She has come for her follow-up. What is that one test which we will be doing for knowing the, the 3 monthly testing? What is it for sugar levels? Perfect, HbA1c karenge. So now my question to you is that you are an intern, this is the patient in front of you, KW lesion hai, pass positive hai, you want to do HbA1c testing, what is the Vacutainer that you will use? This is exactly how the questions are going to change, and even for the upcoming exams, which Vacutainer do you do sugar HbA1c testing in? That's the trick question over here. That is what I want to ask everyone. So you will say that, ma'am, I have learned that any kind of sugar testing on this planet, any kind of glucose testing that we have on this planet is done in gray Vacutainer. G for G, any glucose is done in gray. Matlab, if you would have asked us fasting blood sugar or random blood sugar or postprandial blood sugar or oral glucose tolerance test, कोई भी glucose thing you would have asked us, ma'am, any glucose and sugar related thing, I would have put it in gray Vacutainer. But if I now ask you glycated hemoglobin, HbA1c, what is it? Glycated matlab sugar, but it is testing hemoglobin. Glycated hemoglobin is not done in the gray Vacutainer. This testing is done in the routine purple wala Vacutainer. And that is the trick in the question. Anything asked for glucose is done in gray, but glycated, jisme hemoglobin assessment hai, that is done in lavender. So this is another variation of how this question can come, which should again give you a little bit of confidence. Let me know, do you think things have changed around over here? Do you think that the question has changed? No, it's the same medicine question. It started off with a pathology image, how it's correlated you with your clinics and how you will collect the blood. So it's just integrating a lot of things from all the subjects under one roof, but you will be able to answer it if you've read all the subjects. I think this one question is simple to everyone. Let's do one more question. Let's get a little bit of more confidence further. Let's start with question 2. There's a 28-year-old young female who's come to you with chronic diarrhea, there is bloating and significant weight loss. She has started feeling fatigued and has noticed a decrease in appetite. Lab testings show iron deficiency anemia and a small bowel biopsy has been shown below. Histopath has been shown. A and C, it is the two options that I'm getting. Some of you are putting up Crohn's because I believe everyone loves Crohn's disease. Crohn's hota hai na, if Crohn's is there in the options I've seen, 40% of the students will pick up Crohn's. But the answer to this question is not Crohn's. The other set of students are right. This is a case of celiac disease. Again, before I told you yesterday also, and someone very rightly said in between, ma'am, things are becoming a little more easier to diagnose. That is what I'm trying to train you towards. Till now, you've hyped it up a little too much. Okay, question will be lengthy. How will I attempt? Maybe I don't have that integrated, ma'am. My clinical knowledge is not so good. My clinical acumen is not on the point, is not precise. How will I diagnose? And suddenly you realize that lengthier the question is becoming, jitna zyada clinical, radiology, histopathology, more things being written, life is becoming easier and sorted for us. Only one thing you have to take care of. Practice more of these questions so that time management happens. This is what you will be needing in the exam. You will be needing very good time assessment. Okay, coming back. Yes, this is celiac disease. Many of you answered Crohn's. Guys, firstly, for Crohn's disease, can the patient have diarrhea, weight loss? Yes. But remember, for Crohn's disease, you will always see a hallmark in pathology. Crohn's disease is a granulomatous disorder. Granuloma dekhega. That is very, very important point that you have to notice over here. So which I'm not seeing. So granulomas are not seen. Ulcerative colitis, without giving the history of ulcers, how can you see ulcerative colitis? Ulcers and what? Ulcers and pseudopolyps. Till the time ulcers and pseudopolyps are not mentioned, again, how will you mark ulcerative colitis? Not happening at all. Coming to last one, irritable bowel disease. Irritable bowel disease is a DOE. What is DOE? Medicine mein diagnosis of exclusion. You never give your first diagnosis as irritable bowel syndrome. IBS or irritable bowel syndrome is pathology, histopath, microscopy, normal. Ma'am, everything is ruled out. It is neither Crohn's nor ulcerative nor celiac. Then it's a diagnosis of exclusion. But yahan I am seeing something. What am I seeing? Now this picture needs to be highlighted. So let me tell you the normal versus the picture over here. Normal. First guys, look at the, quickly tell me, because you must have seen abhi last year questions if you pick up na, examiner has understood that you guys have lagaud ratta of all the photos in path, and examiner has understood this, that you have a set of images that Preeti ma'am has given you and wo ratta laga liya. So now what is the examiner saying? He's saying, let me test you. Do you even know normal? Like last year he gave you a picture of a normal glomerulus. So are you able to pick up what a normal structure looks like? So now whenever you read a pink and blue picture, normal bhi dekho. So if you look at normal, you will see what are these structures, what are these finger-like projections known as? These are referred to as the villi. These are referred to as villi. And what are these round things at the bottom known as? These are referred to as crypt. So these are the two things which every normal intestine has, right? But suddenly when I look at a case of celiac disease, when I'm picking up celiac, you will realize, ma'am, those villi have become flattened. All those villi are gone. Those villi have become flat. Villus atrophy has occurred, isn't it? And imagine, rule of the universe. If something will be less, something else will compensate, which means that if the examiner is gonna give you a lot of notices and trying to put your morale down in some way, we will come back and fight with the universe, and we will fight and we will come back definitely. So kuch kam ho raha hai, so we will increase. This means we will increase our effort. What is going to increase? I realize these round structures have increased. That there is crypt hyperplasia. So can you see that villi are becoming flat, but crypts are becoming more? One decreases, one increases. So is the overall, like for example, earlier this was say 1 mm. Overall, ma'am, this is still 1 mm. Can I say the overall thickness is the same? Do you all agree with me? Because I realize that if one thing is becoming less, the other thing is becoming more. So definitely the overall thickness is the same. Okay, now tell me one thing guys, why did all of this happen? So this is a case of celiac disease. Ma'am, I have understood. I can see wo villi bilkul flat ho gaya hai. There is villus atrophy that has occurred, and I can see these round structures have come up very above. So this is crypt hyperplasia. This is celiac disease. What else was there? I could see a lot of D's over here. Means patient had diarrhea. Patient had deficiency, iron deficiency. Iron is absorbed from which part of the intestine, guys? Iron is absorbed from duodenum. So kuch to duodenum mein problem hai. And that is why small bowel biopsy was taken. So listen to me carefully. When I'm dealing with a case of celiac disease, I don't think this much, so everyone knows na, that I'm talking about gluten sensitivity. These are the people who are sensitive to gluten. Why do they have a problem with gluten? They will always come to you saying, I had 2 chapatis or something of wheat or something of oats, and after that I started having diarrhea. After that I'm not able to digest it. Some gluten problem they have. Why? Because they have HLA DQ2, DQ8 problems. They have genetic issues. That is the reason that they are having this problem. DQ2, DQ8, exact DQ numbers are asked. So DQ2, DQ8. So another D has a problem, and that is why these patients, they will say we ate 2 chapatis or we had something of wheat. After that we started having diarrhea. And which part of the intestine is maximally affected? Very good. Everyone's right. Ma'am, duodenum effect hoga. And abhi we studied, if duodenum is affected, iron deficiency is definitely going to occur. 2 Ds ho gaye. We've done duodenum, we've done diarrhea. Now it comes the real correlation. I want to correlate this with dermapath because I realized that these same people, after they were having chapatis or wheat or oat, they started having a skin problem also. This is a classical history. They will say, when I had that food item, after that I started having these kind of lesions on my skin. So what is the skin problem that I'm talking about over here? That's another D. Very good. Dermatitis herpetiformis. But go into the logic. That is what the dermatology educator and the questions are going to ask you. Logic kya hai? Why is this patient having? Because when this patient was consuming gluten, let's assume that gluten matlab wheat, okay, chapatis he has had by mistake, he had it. And now when we talk about gluten has resulted in IgA type of antibodies. Then this patient ended up having IgA antibodies. IgA antibodies ne attack kara to the intestine. IgA antibody has also attacked the skin. So the intestine will also go, the skin will also go. So it's the same antibody which is going and attacking two places. That is why patient has dermatitis herpetiformis. And look at the lesions. You must see the skin part also. Look at the lesions. You will say, ma'am, I can see. Can you see these water-filled vesicles? Everyone. That is how the dermatology educator will ask you a question. There are vesicles, and niche it's all red. It's all reddish color base. There is a red color base and there are vesicles, bulla, water filled. So dermatitis herpetiformis shows you what lesions. What are these small mountains that are becoming? Come on, coming down to dermatology. Ma'am, these are IgA deposits and these are known as tip lesions. Go back to your dermapath questions, and that is a very important correlation. Abhi tak a simple one-liner used to come. It was tip lesions are seen in which disease, and we had always learned that instead of learning as dermatitis, you will learn it as dermatitip. That is how I used to learn it. Dermatitip herpetiformis. So remember, dermatitip herpetiformis में tip lesion दिखता है. That is what we had learned. But from today onwards, they'll change it. They will say, अच्छा, what is this tip lesion? It is IgA antibody. After which food consumption can it happen? It can happen after gluten. What else will the patient have? He will have diarrhea, duodenum involvement. And if you want to treat, what is the treatment that you have for dermatitis herpetiformis? I think this also everyone knows. That is going to be dapsone. So go back to your, so many D's have come now. Go back to your dermapath and you will study this in dermatology, that how do you treat a patient? Dermatitis herpetiformis ka treatment kya hai? Number one, you give dapsone. Number two, you have to give them a gluten-free diet. You have to tell them that do not consume gluten and have dapsone, and you know this is a relapsing condition. Till the time the patient will not have gluten, till the time the patient will have dapsone, patient theek rahega, badhiya rahega. Once he starts consuming gluten and once he stops taking dapsone, after 2-3 months the lesions will come back. So it's a very intermittent periodic kind of a thing. But DD dikha question mein, this is celiac disease, and I think everyone, you've correlated this with everywhere possible, right? You've done the pathology, you've done the derma aspect also. Yeah, that is also something. So yeah, you are right. What is gluten? Everyone has been like, bro, cereals to ma'am pata hai hame. I'm not gonna write it. I think this everyone knows. Barley, rye, oats and wheat. These are the things. So whenever someone comes to you for counseling, for consultation, that I have a gluten problem, what are the things that I don't have to eat? Barley, rye, oats and wheat are the first things, or the great chunk of things that you have to remove from him. Zinc also helps. Yes, there is evidence, Dr. Mustafa, there is evidence of zinc also. But again, dapsone remains the mainstay of treatment with gluten-free diet. Okay. Chalo, this question is also settled. I think we can move a little forward. And of course, Dr. VSK, this is very much important for upcoming FMG. So don't miss out on this. Some of the questions that we are doing are going to help you a lot in solving your medicine aspect at least. Okay, let's start. There's a 10-year-old chota bacha who comes to the clinic with sore throat. Okay. I know this is a very typical question, but I want you to start breaking down things and come to an answer. Try answering. Answer to sabne de diya. I know I was not expecting a wrong answer here. 10-year-old chota bacha comes to you with history of sore throat. What is the differentials or the most important things from microbiome point of view? Young kid and he's coming to you with some kind of a sore throat. I think the most common is strep throat that everyone will think of. Ma'am, streptococcus infection. One more thing that you should be thinking of is, by chance, with this sore throat, if I would have said there is a lymph node also, could you have thought of छोटा बच्चा having infectious mononucleosis, possibility है, yes, because that also has गला खराब, that also has sore throat with a lymph node over here. So that could be one element. अभी तक this is what I think. But when I start reading further, he has dark color urine. Now dark color urine basically something like this. What is this, guys? Ma'am, dark color urine means cola color urine, and as soon as I read cola color urine, there is obviously only one disease coming to my mind, and that is PSGN. That is settled for me. So I believe ab kuch nahi hai, it is no infectious mononucleosis or anything. It is post streptococcal glomerulonephritis. But now tell me, PSGN is what? Ma'am, number one, P for post, P for pediatric. It is seen in pediatric population. I have seen that. ये 10-year-old बच्चा है. Streptococcal, so of course the patient will have sore throat. Yes, I can see that also. And then glomerulonephritis. So which kind of nephritis is it? It is a nephritic syndrome. Nephritic syndrome has what all? I can see that. Cola color urine to samajh aa gaya. Whenever you get nephritic syndrome case, try to look out for these things in the question. What are these things? Number one, try to look out for hematuria. Does the person have blood in the urine? Of course, there is blood in the urine, dark color urine. And आगे देखो, you can see presence of red blood cell casts in the urine. Hematuria, pakka ma'am. Okay, is the urine output also decreased? Can I see that? Yes, complaints of decreased urine output, oliguria mentioned. Is there any history of hypertension? Again, some things will be there, some not, but yahan this is also there, elevated BP. And then finally, is there a case of azotemia? What is azotemia? Azotemia is an increase in blood urea nitrogen. Increase in blood urea nitrogen. Maybe exactly one measurement is not there, but at least elevated serum creatinine levels are there, so kidney is being affected. I am seeing everything that is going in favor of nephritic syndrome. I can say that there is a pediatric person, there is sore throat also, there is nephritic also, and then of course comes your histopath image given here. I know many of you did not pay much of attention, but let me tell you, this is a case of post-streptococcal glomerulonephritis, which number one shows you cola color urine. What is this gross appearance? What is this known as? There's a kidney, and that kidney has many red colored dots on it. Ma'am, imagine some insect bites you. If an insect bites you, to red ho jayega, area will become red. Flea, bitten, kidney. If an insect bites us, to red area. Similarly, in the kidney, what has happened? We can all see these red, famous pictures, especially students. Abhi immediate exam, July 30th, FMG students. Flea bitten kidney is very important. So please come back. Flea bitten kidney is seen in cases of many cases, but one of them is PSGN. But hota kya hai? What is this red color dot? Ma'am, red means blood. This must be some hemorrhage. These are pinpoint hemorrhages. These are nothing but pinpoint hemorrhages. That is why that area is becoming red color. Okay, chalo, now comes this picture which no one really likes. Immunofluorescence. I'll ask you a simple question. Zoom in and see. Just focus on this much of area that we have over here. I want to ask you that is the green color the same everywhere, or suddenly in between you will say, ma'am, thoda sa it's shining a little more. This area is shining a little more. This area is shining a little, as if stars are shining in between. Hai na? Little shininess is coming over here. So this is referred to as the famous starry sky appearance. Starry sky pattern is noted in PSGN. So coming back, was this the picture given to me? Yes. Sudden areas of shining. This is the starry sky pattern given, and now I am pakka sure that this is a case of PSGN. Again, coming to the same point, na, let the examiner talk so much that every point is like writing a short note for the disease. But look at the other diseases also. Okay, why is this not a case of MPGN? MPGN, I've given you this hint. MPGN, 2 lines. What does it show you? MPGN shows you the very famous tram track appearance, right? Tram track is not seen over here. MPGN mein tram track ka case hoga, not seen. Acute tubular necrosis. I just now told you, right now we studied there has to be a muddy brown cast. Something muddy brown, dirty because necrosis hai. That is also not seen. Why is this not minimal change disease? Because as far as I know, minimal change disease also occurs in a minimal bacha, it also occurs in a chota sa kid, it occurs in a pediatric population. So minimal change disease did not occur because minimal, is it nephritic or is it nephrotic? This is nephrotic. So what is the, will you see all these ho-ha features over here? Nahin. This is not what you're going to see. What are you going to see? By chance, it, chalo, maan liya, this history was not given, it was a bacha. What photo would have been here that you would have selected minimal change disease? I think everyone knows it. When you are talking about minimal change disease, you see only a minimal bacha, chota sa bacha, pediatric population, and minimal change. So look at this picture. First photo, look at the picture above. Can you all see these podocytes? Yes, we can all see these feet. Feet matlab podocytes. But in the next picture, can you see those podocytes are all vanishing as if they have flattened? So if it would have been a case of minimal change disease, I would have seen effacement of foot processes. So that is not seen over here, means this, without this picture. Why is this black and white? What is this black and white thing? This is electron microscopy. Can I say without seeing the gold standard electron microscopy in the exam, minimal change disease nahi mark karna? Till this picture of feet going flat, till this is not mentioned, you will never ever mark MCD. That's the rule that you have to follow, because gold standard has to be there. And meanwhile, many of you correlated this with the medicine aspect also. What is the treatment of minimal change disease? It shows you not just steroids, but I want to tell you that it shows you an excellent response to steroids. It's not just responsive, but it's most excellently responsive to steroids. 100% response to steroids is known whenever there is a feet related problem. Prednisone, steroids, yes, perfect. Everyone's got this question right. So I guess we are ready to move forward and move on to the next. Another very, very important question coming up our way. Okay, let's start. There's a 30-year-old. I hope everyone's enjoying the session. It's not becoming monotonous and you're gaining confidence. The point of this session is that confidence badhega. Every chapter you are touching upon, slowly you'll get to know that, even I can solve this. This is not a new pattern that has come which I can't crack, which this is very much doable, right? Okay, so 30-year-old male patient has got multiple small brownish macules on the lips, oral mucosa, hands since childhood. Okay, he has a family history also that is present, and there is intermittent abdominal pain and intestinal obstruction. Palpable mass is there, so based on this, picture is also given. I think I've got an example of classical Peutz Jeghers. So dekho, abhi tak what used to come na, they used to ask you a simple question, simple one-liner. One-liner used to come, what kind of polyp is this? Arborizing, Christmas tree. So they used to ask you, Christmas tree polyp is seen in which disease? That is what the question was. Now they've changed it. Now they've given you an entire clinical history over here, and then it becomes Peutz Jeghers. So let us study Peutz Jeghers. I'll touch upon the other topics also. When I talk about Peutz Jeghers syndrome or Peutz Jeghers polyp, I think this much everyone knows that this is related to a lot of 11-11. Matlab, the age is usually written as 11 years. So it will start off. Onset will happen in bachas only, 11-year-old. And the gene that is involved is also very good. STK11. STK11 gene. Everyone is so nicely giving me answers, as if sometimes I feel I've taught you something in a previous class and you guys in that same order you start answering it in the next class. So I feel that you just picked it up and so religiously you have just embedded all of it in your memory ki jis order mein padha tha, bas same order mein you are going in the same bullet manner, which is so nice to see. So now I see that the onset is 11 years and the gene is also 11. Okay, so here also they said that bachcho mein hua hai, this has happened since childhood. What else? So P for, ma'am, this is the hint. This syndrome will always have pigmentation. I can see pigmentation so beautifully on the skin and the lips over here. Was that written in the question? Yes. Brownish macules on the lips, the oral mucosa and hands since childhood. So history, although right now he is 30 years old, but this history has been there since that 11 years old, so ye problem hai, right? Okay, now coming to one more thing. P was okay for Peutz Jeghers pigment, but P is also for a polyp. And what is that polyp history? It looks like a tree. Now let me tell you a core pathology question that will come. What if the examiner is wanting to test ke ye log sirf medicine padh ke aaye or have they also studied path and done their basic science as well? Okay, everyone knows this is looking like a Christmas, not a Christmas cypress tree, but a tree at least, है ना? They will ask you what are the branches of the tree made up of. Who makes these branches of the tree? So who has gone and divided it? Remember, this is smooth muscle. This is smooth muscle that has gone and divided it. So what kind of a polyp is it? Have we studied? This comes under hamartomatous polyps. This comes, no, this is not hyperplastic. This is hamartomatous. And before that, do you guys remember what is the definition of hamartoma? Hamartoma का definition, basic general path. Hamartoma means hamara tissue, my own tissue, right? Nothing from outside. If this is intestine, I'm talking about intestine. I'm not talking about lungs or pancreas or stomach. No, I'm still talking about intestine. I am saying the smooth muscle from here has gone everywhere and made branches of a tree. So it's hamara tissue. It is my own smooth muscle which has gone and made branches. That is why it is a hamartomatous polyp. So remember, P for putes, P for pigmentation, P for wo tree wala polyp. And where is it seen? Putes, jaggers. So remember, the most common site is small intestine. It is going to be the jejunum. So the most common site is going to be jejunum. That is the entire history that you have for Peutz-Jeghers syndrome, which was exactly what was there. So ध्यान से देखो, over here, have they given you the exact tree wala? No, na, they won't give you a nice beautiful tree in front of you and serve it on a platter and say answer kar do. But if you look a little carefully, they have shown you those lines going in between. Have they shown you that division going, that branches going in between? Those branches are nothing but that Christmas tree or that smooth muscle that they are trying to tell you. Nahi bhi samajh aaya? Never mind. You could see the pigmentation and you could see a polyp. It had to be Peutz-Jeghers. What about the other syndromes? Jaldi se let me know. When I talk about neurofibromatosis 1, why have they written NF1 over here? Is there any skin problem that you could have confused it with? Could you have confused it with cafe au lait spots? Right? So maybe they would have settled in for cafe au lait spots, but the problem is that neurofibromatosis will have neurofibroma, that neural element has to be there. That is totally missing. Only skin cannot give the diagnosis. So this is definitely ruled out. Why is it not Cowden syndrome or Gardner syndrome? These also have polyps. Cowden syndrome, I hope you remember, Cowden syndrome is going to be which genetic problem? Ma'am, it is a P10 gene on chromosome 10 problem. P10 gene chromosome 10. Remember, we used to become kids while learning this. P10 chromosome 10 Cowden, rhyming P10 chromosome 10 Cowden. So that is P10 gene problem. So kaun sa wala? What else? How would I have known that by chance if this would have been a case of Cowden? What would have been mentioned in the paper? N for which gynae tumor? Endometrial cancers would have been mentioned in the case. Which surgery thing would have been mentioned? Thyroid cancers would have been mentioned. Intestine में polyp होता? Yes, polyp definitely होता, but one more tumor. And from P you make a B, so that would have been breast cancer. So this case, not like polyp यहाँ भी था. This would have also had a polyp, but other than polyp, patient would have had endometrial cancers, thyroid cancers, breast cancers. Then I would have started selecting Cowden, chromosome 10, P10. Nothing of this is given over here. This is not a case of Cowden. Settled? Acha, Gardner. Gardner, I think, is a case of FAP. Gardner is a type of FAP. What do you guys understand by FAP? FAP is very famous surgery question. Familial adenomatous polyposis. How many polyps would be mentioned in the exam? Ma'am, at least 100 polyps had to be mentioned. That is the cutoff criteria for FAP. Over here, they've given me one tiny little palpable mass and one tiny little polyp. This criteria was not mentioned. So again, I'm not gonna pick up Gardner syndrome also. It's a classical case of Peutz-Jeghers. So let us limit ourselves to this, right? Is that okay for everyone? Yes. Dr. Shahrukh, of course, right now, if I start getting you questions on every option, then the same question will end up getting repeated. So instead of that, it's always better do one question and then also find out why are the other options not a situation. Otherwise, if I now show you a question on these three things, it will become so obvious and biased na that acha it is Cowden. That is going to be time waste. The better time saving technique is do one question and rule out all the other options so that you know how to come to an answer. Okay, too much of, we've spoken too much about systemic path. It's time to change a little. Let's come to this. Let's start answering a question. There's a 10-year-old Afro-American boy presents to the emergency department. Patient has hepatosplenomegaly and skull x-ray has been shown out here. Laboratory investigation anemia hai, reduced hemoglobin, elevated LDH, red blood cells ka peripheral smear has also been shown over here. Which of the following is the most appropriate initial treatment for this patient? Okay, what would you be doing at this point of time? There's a lot of confusion that I can see, which I did not expect. But the two confusions that I can point out is hydroxyurea versus fresh blood transfusion. Okay, so firstly, did you analyze the disease? Disease ka naam ban gaya? Did you all think it is a case of sickle cell anemia? Yes. Okay, so now there are two possibilities over here. Let me show this to you once again. This was the picture given to you. Could you all identify these sickle cells that were given? Classical sickle cells, there's no doubt about it, ma'am. They're looking like a boat, like a sickle. So when sickle cells are seen, it is a definitive case of sickle cell anemia. After that, I pretty much don't have much of a doubt. If sickle cells wouldn't have been seen, by chance, nahi dikhta, but all these features would have been there. Hepatosplenomegaly bhi hai, skull x-ray is also showing this, anemia is also there, LDH is also increased, every feature is there, but sickle cells are not seen. Then you would have had a doubt, is it a trait or is it a sickle cell anemia? Then in that case, doubt hota ki this is not seen but baki sab hai, then you would have started blood transfusion, because that time you would have only known that hemoglobin is reduced. Anemia hai, but kaun sa anemia hai, that is not known. So then the safe option would have been start fresh blood transfusion. But guys, once you see the classical, so many of them, classical presence of sickle cells, then ideally your treatment should revolve around what? Then your treatment should revolve around hydroxyurea therapy. So please note that in case sickle cells wouldn't have been seen, I would have gone for blood transfusion ke anemia theek karo, then I'll find the cause, then I'll do big tests, I'll find what is the anemia, then I'll think of the treatment. But yahan to sickle cells are seen na, classical sickle cells are seen. Of course you need confirmation, but this is definitely a case of sickle cell anemia. So I'm going to start with hydroxyurea. Why do we start hydroxyurea therapy in sickle cell anemia? Why is the treatment of sickle cell anemia? And actually my answer would also have been both. You don't just put the patient on hydroxyurea therapy and you don't correct the hemoglobin. Aisa nahi hota. You have to take both things. You give hydroxyurea also, you give blood transfusion. So even my answer would have been A and B both. But here MCQ hai, you have to select one best answer. So that is why I wanted to discuss this question. So now tell me, in a sickle cell anemia, why do I give hydroxyurea? Because I realize that if I want to convert, if these are sickle cells always form whenever the oxygen concentration is low. Whenever hypoxia will happen, these normal cells will become sickle cells. So you will say, ma'am, hypoxia nahi hone dena. You do not have to allow hypoxia. Hydroxyurea will increase fetal hemoglobin, and I think I have studied in pediatrics that fetal hemoglobin has increased oxygen affinity. It will make sure that hypoxia does not happen, right? Hypoxia does not happen. So again, asking you one more thing. I'll come back to your queries that you've asked me, guys. So remember, we'll give hydroxyurea because it will increase the fetal hemoglobin, it will increase the oxygen affinity, these sickle cells will not form. Now, many of you still have the same question coming up to me that, ma'am, out of these two, they had asked the most appropriate initial treatment for this patient. So now again, listen to me once again because I just explained this. Would you be giving ideally? Forget question. Abhi thodi der ke liye NEET NExT exam ko bhul jao. Forget that. Look at a patient coming to you and patient has this crew cut appearance, patient has sickle cells. Would I ideally be giving both? There's no one above the other. I'll be giving both, right? I'll correct the anemia also. I'll be giving hydroxyurea also, correct? But on the other hand, if this is an MCQ where I can clear cut see sickle cells, matlab this is a case of sickle cell anemia. Can this patient at any point of time go into crisis because this patient has hypoxia, sickle cells are being seen, hepatosplenomegaly is there, then there is elevated LDH, then you have classical crew cut appearance. Can this patient go into crisis? So at this point of time, you will be giving both, but what is your preference? You have to correct this oxygen ASAP, and for that you will have to first start the patient on hydroxyurea. So then after that, of course, meanwhile, you will start the patient on multiple, not one. You will start the patient on multiple units of blood transfusion. There is no doubt about it. I hope this question is clear to everyone that why are we selecting hydroxyurea over fresh blood transfusion? Because ideally, dono साथ साथ देना है. But what is the one best thing over the other is that to prevent the crisis, quickly start giving hydroxyurea, because meanwhile the oxygen levels will be corrected, fetal hemoglobin will elevate. That is going to take time. So your initial treatment should start off as this, and of course for only correcting the hemoglobin, the fresh blood transfusion goes on, right? See, if I put it in a very layman term na, if they would have asked you what is the best action you would take for any anemia on this planet, be it iron deficiency, megaloblastic, sickle cell, thalassemia, for any anemia of them on this planet, my first investigation and first treatment is blood transfusion. But here they've asked you for this particular patient which has so many features suggestive of sickle cell anemia. Now in this situation, of course, we are going to have hydroxyurea as the treatment. Is this question now settled to everyone? Yeah, it is debatable. Of course, every day I'm getting you one controversial question. Like yesterday, I got you that pedigree chart wala question, which was super controversial. Today, I've got you this question. It is debatable, but at the end of the day, we have to select one best answer. So then that is it, right? So sometimes we will be put in a fix because we are doing MCQs, but in patient scenario, it's different. So ये आज का controversial question था, but I hope now you know what to select and how to approach this question. Now in the other options, Dr. Simran is saying, what if the image would not have been given? Then so you will give, then so you don't know na, it's sickle cell. Then how can you start giving hydroxyurea if this photo is only not given? Then crew cut appearance to can be seen in thalassemia also. Then I have none of these options. Then I will have to go in for blood transfusion only. I can't start hydroxyurea till I know that it is a case of sickle cell anemia. That is exactly what I'm trying to teach you. Photo diya tha, that is why I was confident with sickle cell. That is why I started with hydroxyurea. Photo nahi diya, I am not confident it is sickle cell. I can't start hydroxyurea. I will go for fresh blood transfusion. Everyone's now clear with this. It was all photo based that I wanted to tell you. Chalo, many of you asked me other options. This is totally unrelated. Where will we give phosphodiesterase type 5 inhibitors? These are given in cases of erectile dysfunctions. These are given in cases of pulmonary hypertension, for vasodilation. So this is nothing to do with any of the sickle cell anemia or anemias over here. Similarly, monoclonal antibody. Now there are so many MABs. There is no end to it. Rituximab, pembrolizumab. So monoclonal antibodies are against some CD marker. Like for example, I said rituximab, that is anti-CD20. So again, these are against some kind of CD markers, which is not at all needed over here. So wo to ab bilkul gone. These two are totally useless options. The only confusion in the exam also will be A and B. Take home message is, सिकल सेल का फोटो दिया था, the patient was being told as sickle cell anemia. I wanted to prevent crisis, so I started on hydroxyurea. If sickle cell photo would not have been given and I wouldn't have had a diagnosis of SCA, my initial therapy would have been fresh blood transfusion. I hope now every query is settled over here. Yes, can we proceed forward, guys? Should we switch once again with the options? Everyone settled with it? Ab no confusion na? Yes, please a quick heads up on that. Let's go to something very simple, ma'am. Complication ke baad, your mind needs to declutter. We need to come back to something simpler. So here you have this question. Simple wala. 45-year-old female presents to the physician with a painless lump in her neck that she noticed while performing self-examination. Physical examination revealed enlarged, firm and mobile thyroid nodule. FNSC of the nodule is performed. Histopath examination has characteristic nuclear features. Something has been shown. What is this, ma'am? Thank you for this, because after that super controversial question, we wanted to settle down for something super easy. And this is a case of papillary carcinoma, evergreen question, not going anywhere. But how is it going to change with the exam patterns? These photos are definitely going to change for us. Firstly, lump in the neck, again painless is okay for us. And there is a mobile thyroid nodule for which FNSC and histopath was done. So this can be so many. This can be any of the tumors. For that matter, mobile thyroid nodule could have been colloid goiter also, right? It could have been a nodule also. So the final features written over here which give me a diagnosis is nuclear features. ये कौन सा nuclear feature था? What was shown? No, this was not orphan annii. I could see a nucleus over here, and inside that nucleus I can see one dot sitting in it. I can see a dot sitting inside it. This is intranuclear inclusions. This is not orphan Annie. This is intranuclear inclusions. Although you want to see orphan Annie all the time, but ye intranuclear inclusions are. So look at this, guys. What are the features that you will see in a case of papillary carcinoma thyroid? Something that you love, and that is this. I know you guys love this cartoon character. You love how the white eyes are shown over here for orphan Annie, and you can see how the white nuclei are shown. Ye hamara favorite hai, ma'am. Kuch bhi hoga, we will always search for this. This is a case of orphan Annie eye nucleus. Perfect. After that, what I wanted to show you was this. Look at this. Inside the nucleus, there is a dot. So what do you call these? Intranuclear inclusions. These are INI, intranuclear inclusions. What else? Ma'am, in the next photo, I can see that there is a nucleus with a line. What do you want to call it? Ye kya appearance bana? Nucleus with a line, intranuclear groove. Can I call it coffee bean? Dekho, did you realize everything is for nucleus? The nucleus is looking like orphan Annie. The nucleus has inclusions. The nucleus has a groove for coffee bean. Papillary carcinoma thyroid has to have nuclear features for the diagnosis. And something that we read yesterday, every papillary tumor shows you which bodies. Ye to kal pada tha. Yesterday's question had the round and round bodies, the famous Samoma bodies. So simple repeat, we have orphan Annie, inclusions, grooves, Samoma body. But that is all. Then I'm talking about histopath. Ma'am, will you see all of these when you do FNAC? Everyone knows FNAC, na? FNAC matlab that needle, before every surgery you put a needle inside it. Is there something that you see only on FNAC in papillary carcinoma? Yes. Everyone has seen chewing gum stretch hota hai, right? You will realize that on FNAC for papillary carcinoma, the colloid is getting stretched. We see something, very good. All the INI-CET aspirants to have to know this. FMG students can skip. Chewing gum colloid is the FNAC finding of papillary carcinoma thyroid. Why? Common sense. Ma'am, FNAC, patla sa needle, 25-27 gauge needle, that is going in the thyroid. Patla sa needle, the colloid will get stuck. All the colloid will get stuck. When you take it out, it will come out as chewing gum, stretchy chewing gum, because the needle was so thin, the needle was so patla. Obviously, no, for thyroid, you use a very thin needle. Usually you use 27 gauge needle for thyroid. Why? Because thyroid is present at a very vital. You have so many vessels, trachea, everything around it. You don't want to press on anything. You use a very thin needle. And this colloid gets stuck in the needle. That is why it comes out as chewing gum colloid. I hope this question is also easy, because as I said, after a tough question, we wanted something simpler. Tell me 2 questions related to surgery. Number 1, what is the mutation? Number 2, what is the spread? And number 3, what is the prognosis? 2-3 questions of surgery quickly that I want you to answer. Yes, what is the mutation in papillary carcinoma? Very good. We see the BRAF V600E mutation. I will talk about BRAF in a while. Acha, someone said RET. Okay, nahi. Dekho, chalo, RET wala I will tell you in a while. Abhi ke liye remember, it shows you the presence of BRAF V600E mutation. Spread kahan hota hai? This usually goes to lymph nodes. So now look at, forget questions. I want you to forget questions for a while, because we get into the world of textbooks and we forget we are dealing with patients. Whenever you will be dealing with a thyroid nodule like this, say for example papillary carcinoma thyroid, very commonly you will see cervical lymph node chain also getting enlarged. In fact, kai baar, so many times I have seen patients where thyroid, when I palpate the thyroid, I don't see anything over here, because tumor is very chota sa. Tumor is hardly 1 centimeter. But I will hardly see anything in the neck, but I will see big lymph nodes over here. And then when I put my needle in the lymph node mein papillary carcinoma has spread. The spread is always lymphatic. So much so that the tumor initially might just be 1 centimeter, but lymph nodes have become big swollen. And the prognosis is excellent. It's one of the best prognosis cancers of the thyroid that a person can have. So please note, these are the points that they will ask you in surgery. But I saw a lot of confusion. Abhi genetics ka confusion bahut zyada tha. Now listen to me a little carefully. So now I'll just try to make a small table so that your confusion is settled in a chota sa table. We have something called papillary carcinoma thyroid. follicular carcinoma thyroid and medullary carcinoma thyroid. I know you guys are confused with genetics, which we will try to settle over here. So please remember, papillary carcinoma mein, if one genetics is asked, you are going to mark BRAF V600E, that you have settled. Follicular carcinoma, for those who said, most common is RAS mutation, and medullary carcinoma is RET gene. Ab dhyan se suno, because here you will do lots of mistakes in the paper. I want you to learn a rhyme like a student, school going student. What is school going student ka rhyme? RET 10 med men. Can you decode this? RET 10 med men. You will say, ma'am, RET I know. RET is the gene that you told me. Chromosome कौन सा है? Chromosome 10 होगा मैम. RET 10. Chromosome must be 10. Med means what? What is the med over here? Ma'am, med must be for medullary carcinoma. And what are the syndromes? Men 2A, men 2B. Repeating, RET is the name of the gene. 10 is the chromosome number. Med is medullary carcinoma thyroid, and men is men 2A and men 2B that you have. So remember, RET 10 med men hamesha yaad rahega. RET is gonna be for medullary carcinoma. However, the twist in the story that comes is, if they give you RET PTC fusion, if RET PTC fusion is there, you will say, ma'am, RET to humne padha tha RET 10 med men medullary carcinoma, but that was only RET. If I fuse RET with PTC, papillary thyroid cancer, PTC, papillary thyroid cancer, now what tumor will you mark? Now you will mark PTC. That is why I was wondering why in the beginning many of you were saying papillary ke liye RET mutation, because you guys are getting confused. If only RET is mentioned in surgery, so you will think of RET 10 med men. RET matlab only RET mentioned medullary carcinoma. But if RET and PTC fusion occurs, so RET and PTC means papillary thyroid, then you will be marking papillary thyroid cancer. I hope now all the confusion, this is the shortest possible table ever made in the history for genetics of thyroid cancers. Itna to you have to know, and there's no scope of confusion that you can handle out here. I hope everyone's okay with this. Yes? ठीक है, चलो, as I said that again we are focusing too much on what? We are focusing on thyroid. So why don't we solve one more question? Maybe we can have one last question of the day on the same pattern. A 45-year-old female presents with fatigue, weight gain, cold intolerance, constipation. Classical features of, forget the question, classical features of hypothyroidism. Very classical, ma'am. Weight gain, cold intolerance, constipation. Then physical examination shows dry skin, coarse hair, and diffuse non-tender enlargement of the thyroid gland. Yes, everyone's given me a correct answer, but I want to read further. Diffuse non-tender enlargement. Okay. Lab investigations increased TSH. TSH is increased and decreased levels of free T4. Means again I'm entering into a case of hypothyroidism. Clinical was also hypo, lab is also hypo. FNAC shows lymphocytic infiltration. कौन सा वाला hypothyroidism? Ma'am, when lymphocytes are mentioned, this is a case of Hashimoto thyroiditis. Superb that all of you have given me a correct answer. Hashimoto's thyroiditis, क्या होता है Hashimoto's thyroiditis? Does it show you Hurdle cell changes? Yes, it does. And Hashimoto's is an autoimmune disorder. Autoimmune disorder means that it is nothing to do with iodine intake in the diet. This is not a dietary phenomena. This is not going to affect the HPA. This is not excessive production of anything. Autoimmune hai. Autoimmune matlab some antibodies like what? Anti-thyroglobulin, anti-TPO. These antibodies are the ones which are going to come and destroy my thyroid. Ab khud socho, the thyroid is destroyed. Thyroid is destroyed, that is why the thyroid hormones are not coming up, right? Thyroid ही destroy हो गया, so the thyroid hormones will not come up, anti-TPO, anti-thyroglobulin. So, as I said that this is what you come down to. Again, you will say, ma'am, ये हमें दिखा दो. All this that you have written, show us a picture. But before that, normal thyroid देखो. First you need to analyze what a normal thyroid gland looks like in pathology. So I think everyone knows. I will see some pink color, goal pink color things, hai na? So what is this? These are the thyroid follicles. These are all the thyroid follicular cells. And what is this pink color material inside it? That is the colloid. This I think I know. Follicular cells are there and pink color material is colloid. But what is this extra bunch? ये क्या है? This is some extra cells that are there. Extra cells are, ma'am, outside the follicle. Parafollicular C cells. What is the importance of parafollicular C cells? Parafollicular C cells normally produce what for us? They produce calcitonin. They produce calcitonin. So now I want to ask you one question. Before I go to Hashimoto's, abhi we did thyroid cancers, papillary thyroid cancer, follicular thyroid cancer, anaplastic carcinoma thyroid, medullary carcinoma thyroid. ये सारे cancers करें. Remember, all of these cancers come from the follicular cells, simple follicular cells, whereas medullary carcinoma comes from parafollicular C cells. That is why, tell me, what is the tumor marker for medullary thyroid cancer? Ma'am, it is arising from the C cells, so tumor marker is also calcitonin. Na? The origin is from these cells release calcitonin, so cancer will release too much of calcitonin. That is the logic. So now how could a question come in your future exams if they want to integrate your surgery and your pathology? They will give you a slide of pathology, they will label these cells and they will say which is the tumor that is arising from these parafollicular C cells. So ye wale cells say we have only one tumor, that is medullary carcinoma. And they will say, okay, there is a tumor arising from these cells. What will be the tumor marker? Tumor marker will be calcitonin. Can you revise with me? What will be the genetics? क्या होगा? BRAF होगा, RAS होगा, RET होगा. What is the genetics that you will mark? RET10 MED-MEN, you will mark RET gene mutation. That is how questions are going to integrate. So normal thyroid everyone has understood. Now let me come back to this. Why was this a case of Hashimoto's? Because what was being seen in this picture? So let me show you a case of Hashimoto's thyroiditis. Look at the gross. The thyroid will be overall, pura thyroid enlarge hoga, diffuse enlargement. It's not a nodule. It's not going to come to you as a nodule like this. It's full thyroid enlargement. Next, you will say, ma'am, if I break the word, if you talk about Hashimoto to scientist hai, bhul jao. If you think of thyroiditis means I will have thyroid and I will have itis, inflammation. So if I look at this picture, I see lots of pink, wo hoga thyroid. And then I see lots of blue, that must be lymphocyte infiltration. Repeating, I see lots of pink stuff, that must be all of the thyroid. And then I see lots of blue things and all these blue materials over here, all these blue cells over here, they must be the lymphoid follicles. So now you can imagine now, lymphocytes are destroying the thyroid. Lymphocytes are going to be destroying the thyroid follicles that you have, and that is why thyroid ka destruction hai. That is why patient has hypothyroidism. But if they ask you what is the hallmark of Hashimoto's thyroiditis, hallmark of Hashimoto's thyroiditis are the Hurdle cells. Hurdle cells kaise dikh rahe hain? Ma'am, they are big cells. Suddenly I am seeing something which has become like giant cell. Mega giant cell, बहुत बड़ा cell है. That is a Hurdle cell. Lots of names given to it. Hurdle is one scientist, Ashkenazi is one more scientist, Oxyphil, Oncocyte. This is something which is there in every question that you will realize, and come back, they had it written here also. It shows you the presence of these Hurdle cell changes, matlab Hashimoto, and it also shows you lymphocytes with hypothyroidism. Pakka Hashimoto, this is an autoimmune destruction of the thyroid follicular cells. I hope this is clear because these are the pictures which I've realized students never ever see. And before I end this session, I will give you life lessons also. Sometimes you will feel that you are not being given credit or you are not being given too much of due for how much of hard work you're putting in. So always remember the story of Hurdle and Ashkenazi, because all of us today remember it as Hurdle cells, that is the name. But do you know who actually identified these cells? Was a scientist, Ashkenazi. So that gives you life lessons, that sometimes you will do the biggest discovery of your life, but no one will give you credit and someone else will take that credit. But that doesn't mean that you haven't done anything in life. So although we call it Hurdle cells, but actual description and actual identification was done by scientist Ashkenazi. You can read about this on Wikipedia or Google also if you're free sometime. But that just wants to tell you that you just have to do your work time to time. You might or might not get credit, you might or might not get the reward for it, but you need to be clear in your conscience that you have done your work well. on that life lesson, I'll wrap up the session for the day, and here we come to an end. I hope all of you have enjoyed the session as much as I did interacting with you. I don't know whether you guys are confident or not, but whenever I interact with you and the kind of kind of questions answers that I get, which are so much in sync with whatever I have taught you, it gives me a lot of confidence that we can probably be bombarded with any kind of pattern in the future, but we are pretty much prepared. At least I see that preparation in all of you, and I know you might not have that confidence because you have a lot of things to deal with, so you have that element of self-doubt. But at least I don't feel scared, because I know when these kind of questions will come in the exam, you guys are pretty much well prepared to take it head on, so you are not going to have any problem. Okay, any queries? Telegram, Instagram, there are so many online platforms and social media groups. Anywhere you can put across your query. Any other query, you can even put it under a comment of this video also, right? So anywhere that suits you. FMG videos, Dr. Neha, which videos are you talking about? I have already conducted YouTube sessions in the last month. This time I conducted it well in advance so that you guys don't have to wait till the end moment. So they are already there. Just scroll through the YouTube channel. In the video section, you will find Path and Micro both. But those are not enough. My advice to all FMG students is that we are going to have, we have RR, rapid revision. वो पढ़ के जाना है. That is what you have to study. One more session coming up, guys. That is going to be on July 17th at 12 o'clock. That is going to be microbio sessions. Okay. Right. So thank you so much, guys. For Dr. Umam, grand tests, if you're feeling, I don't know which exam you're preparing for, but if you're feeling that you're not crossing the 150 score in the grand test, let me tell you, grand test is a mock test. It's not set in order to give you overconfidence. It's set in order to put you at a stage where you do mistakes, you learn from them, and you can prepare more. So whatever you're getting in your grand test will always be a little lower in comparison to what you'll get on the final day, because GTs are prepared in that manner to train you to the most difficult level that you can face in the exam. So as I say, grand tests are not for assessing and judging critically yourself. Grand tests are to basically practice, catch on to your mistakes, time management, silly mistakes that you're doing, things like accept, true, false, correct, incorrect, that you don't read, how to limit your question within 45 seconds or 1 minute. उन सब के लिए grand test होता है. Don't take it so, don't judge yourself so critically on it that I did not cross this particular score, so I am not doing well in my preparation. No, take it as like this session was a learning session for you. Reading your videos and notes is learning. Similarly, questions in the grand tests are also for learning. This is a big myth that grand test equals main test. No, grand test equals learning, just like any other mode of learning that you are doing right now. Last 15 days, should you be giving a GT? I think now, if I would have been in your place, I would have not. Because no matter what anyone may say, looking at a grand test score in the last 10 days now does give you an element of, see, acha hua to very good. But if it does not come out, God forbid, if it does not come out well, you will start thinking that, this is what my fate is, and then you'll stop studying for the last 10 days. And last 10 days ka padhai by default, ask any student, is the most crucial part of your preparation. So if a grand test gives you that element of scare and self-doubt, my advice is skip it. No worries. You've given ample tests. Solve questions. MCQ solving is important. Even if you don't give a GT in the last 10 to 15 days, it's not going to hamper you. So you can skip that, Dr. Neha, easily. Okay, so thank you so much for joining in, and I'll be meeting you again on July 17th for the microbio session. Thank you, guys.